In my practice as a board-certified dermatologist and acne expert, I commonly see patients whose acne just doesn't seem to be getting better. And one of the first things we try and figure out is this actually acne or an acne mimicker that might require a different treatment? In this video, I want to break down some of these common acne mimickers and how we can differentiate them from acne. The first one I want to discuss is Pios foliculitis, which also sometimes goes by the name of fungal acne. Pitiosporum folliculitis is caused when a normal yeast on our skin, Malassezia or Pitiosporum, it starts to get a little bit too comfortable, starts to overgrow, and starts to cause problems when it gets into the follicles and causes inflammation. In contrast to acne, lesions, the spots that we see in Pitiosporum folliculitis, they tend to be very monomorphic. They all look the same. In acne, often the spots are a bit more random, some are bigger, some are smaller. In Pitiosporum folliculitis, the spots are generally all relatively small. They all look very similar, and they often appear in these little groups or crops that are close together near each other. In addition, Pitiosporum folliculitis spots are often more itchy than acne bumps. So if we see these small, monomorphic, all looking the same, sometimes itchy and grouped spots, that can be a sign that what's going on, or at least a part of what's going on, is not acne, but instead this issue called Pitiosporum folliculitis. And this is a condition that often responds very well to antifungal treatments or even like anti-dandruff shampoos used like a face wash. The next condition I want to talk about is rosacea. Often acne and rosacea get thought of together, and sometimes people even use the same term for both of them. However, in contrast to acne, which has whiteheads and blackheads, rosacea does not. So if we see inflamed kind of bumps on the skin, maybe even some pus bumps, but there are no whiteheads or blackheads, that can be a sign that what's going on is not acne, but actually rosacea. In addition, rosacea tends to go along with having these kind of redness or flushing issues or broken blood vessels on the nose or cheeks called telangiectasias, and those can be other features that suggest that there may be more of a rosacea issue here than acne. In addition, while acne typically affects kind of younger individuals, adolescents, and sometimes can persist into adulthood, rosacea usually doesn't start to occur until kind of the third to fifth decade of life. So someone who's a teenager and has kind of papules and pustules more likely to be acne. Someone who's 40 to 50 years old or older may be more likely to be rosacea. So we can use those kind of demographic features to help us differentiate them too. Acne is going to be in younger populations. Rosacea is going to typically be in older populations. So if we don't see comedones, if we see kind of redness and flushing and broken blood vessels, telangiectasias, and it's an older individual, that's more likely to be rosacea than acne. The next mimicker I want to discuss is perioral dermatitis. This is a condition where we see these groups of inflamed papules and pustules and bumps that are usually around the mouth, nose, and eyes. They can sometimes be a bit itchy or irritated as well. There can sometimes even be some scaling that looks a bit like eczema. That's where the dermatitis part of this can come in. And perioral dermatitis can often sometimes be confused with either acne or rosacea. But the key differentiating factors here are really distribution. That location more around the mouth, nose, and eyes, and not so much on the cheeks or forehead or other areas. That can really suggest that the issue is perioral dermatitis instead of acne or rosacea. Similar to rosacea, perioral dermatitis also does not have comedones. It doesn't have whiteheads or blackheads. So if we don't see those whiteheads or blackheads, that's again suggesting that it's not acne, that it's something else like perioral dermatitis. We know also that perioral dermatitis tends to be associated with certain triggers, like using steroids on the face, like hydrocortisone or other topical steroids that may have been used to try to help treat this or other problems, but ultimately are perpetuating it, or other kinds of irritants. In contrast to acne, perioral dermatitis, often people have pretty sensitive skin, and so things like retinoids or retinols sometimes can make this worse, and we want to try and help fight inflammation or restore the skin barrier. So anti-inflammatory strategies like pimecrolimus or tacrolimus, these non-steroid anti-inflammatory treatments, or sometimes the same kinds of topical or oral antibiotics like clindamycin, doxycycline, and sarecycline that we use in acne can be helpful here as well. Another condition that can be confused for acne is gram-negative folliculitis. And what can make this extra tricky is it usually happens to people who have acne and have been treated chronically with oral antibiotics, and this long-term antibiotic use has shifted the skin microbiome. Instead of having our normal staph and strep and C. acnes bacteria in the skin, now it's shifted more toward gram-negative organisms that usually aren't that predominant on our skin. And these get into the follicles, and they can cause really inflammatory, deep pustules and cysts and painful acne bumps. They often are kind of more around the nose, sometimes spreading to the cheeks and chin. And again, they often have happened in someone who's had long-standing acne, maybe that's been managed by oral or topical antibiotics without things like benzoyl peroxide to help prevent those shifts in the microbiome. And then we've had this shift toward gram-negative organisms. And now suddenly things are much worse, and they're not responding to acne treatments like before, because most of our acne treatments are targeting C. acnes, which is just a different kind of bacteria than these gram-negative foliculitis bugs, and it needs a different kind of treatment. So here often actually what we will use is Accutane isotretinoin to help decrease oil production, to help restore the skin microbiome, and that's typically the most effective treatment for gram-negative folliculitis, but also using antibiotics that specifically target gram-negative organisms more effectively can be another way to approach this issue. Another mimicker of acne is a condition called Demodicosis, or overgrowth of Demodex mites. We all have Demodex mites. They live on our skin. They're a normal part of our skin microbiome. But in some people, just kind of like what can happen with Pios-form folliculitis, they just get too cozy, they start to overgrow, they start to get into our follicles and cause inflammation. And this inflammation can lead to bumps just like what we see in acne. Now again, with Demodex, we usually don't see those comedones, those whiteheads and blackheads that we expect for acne. So the absence of comedones can again suggest us that we're thinking about something that's not acne. For Demodex, it can look a lot like rosacea, but in my experience, it tends to be a bit more inflammatory and sometimes a bit more itchy than we see with rosacea. It often tends to happen to people who may be older or may have some issue with their immune system, whether it's just immune system kind of senescence that we can get as we get mature in life, or maybe another medical problem like kidney disease or immunodeficiencies or other issues or medications that may have reduced our immune system's ability to control kind of this normal skin commensal organism, these Demodex mites. Demodicosis often responds quite well to either topical or oral ivermectin, or sometimes to other rosacea treatments like metronidazole. The last mimicker I want to discuss is steroid acne. This can happen in people who are taking long-term oral steroids like prednisone, or people who are using exogenous hormone treatments like testosterone replacement therapy. These treatments can stimulate the oil glands in the skin and also potentially can kind of shift around our immune system and microbiome. The lesions, the bumps that we see in steroid acne, they tend to be kind of a bit more like Pios-form folliculitis, where they're more monomorphic, they're all very kind of similar in appearance. They can be a bit bigger than what we see in Pios-form folliculitis, and they often tend to happen a lot on the body. We get a lot of spots on the chest and back in comparison to what we see often in acne, where there tends to be more on the face than on the body, though this doesn't necessarily always have to be the case. Steroid acne, often the most important thing is trying to get rid of that contributing factor, so the oral steroids, if we can try to reduce them or stop them, or if someone's taking testosterone, reducing or stopping that, those often can help a lot. In situations where we can't, we really typically lean on some of our main acne treatments, and often this can respond similarly to acne in general. Using kind of our classic topical or pill medicine strategies can work well for this as well. Well, I hope you found this video helpful. If you have, please give it a like and subscribe to your channel. Your support is really important to make this possible. Ask me your questions about acne and these mimickers in the comments below, and share your experiences so we can all learn from each other. Until next time, see ya!